Posterior reversible encephalopathy syndrome secondary to asymptomatic post-streptococcal glomerulonephritis in a child with sickle cell anemia. A case report. A 9-year-old Saudi girl was presented to our hospital with a fever of 38.5 degrees Celsius, cough, and shortness of breath. Her oxygen saturation was 88% on room air, her blood pressure was normal for her age, and she had no tachycardia. She had had abdominal pain for 2 days that was not responding to analgesics. She had been diagnosed with sickle cell anemia, SCA, at the age of 2 years. On examination, the patient had no organomegaly. Her ear, nose, and throat examination was unremarkable, and her initial neurologic examination was unremarkable with normal motor power, sensations, and reflexes. Subsequently, she was admitted to the hospital and diagnosed with acute chest syndrome on the basis of her clinical manifestations and bilateral lung infiltrates seen on chest x-rays. Her concomitants, abdominal pain, was attributed to vaso-occlusive crisis. She was started on full supportive care, including antibiotics, analgesics, intravenous fluids, and oxygen supplementation, and she was given packed red blood cells once with minimal improvement. During her stay at the pediatric intensive care unit, and after 5 days of exchange transfusion, the patient's respiratory distress and radiologic evidence of acute chest syndrome resolved. However, she developed systemic hypertension and was started on anti-hypertensive medication with slight improvement. Echocardiography showed mild mitral regurgitation with dilation of the left ventricle, and Doppler ultrasound showed patent hepatic and renal vasculature. The results of her blood workup were within normal ranges apart from creatinine, which was slightly elevated. 4 days later, the child had marked elevation of her blood pressure that was followed by seizures and sudden loss of vision. On examination, she was drowsy, had a Glasgow Coma Scale score of 10 on a scale of 15, and was responding to verbal stimuli. She had no signs of meningeal irritation, and results of her motor and sensory examinations were normal. Urgent magnetic resonance imaging, MRI, of the patient's brain showed an ill-defined, non-enhanced area of abnormal hyperintense signaling. The patient's electroencephalogram was reported as normal. She was kept on full supportive measures, including anti-hypertensive and anti-epileptic medications as well as antibiotics, in addition to intravenous fluids to improve renal function. The child started to improve gradually over a 1-week period with full restoration of vision and adequate seizure control. Her general condition improved markedly with an unremarkable systemic examination just within 10 days of her abrupt clinical deterioration. Our patient is currently in good condition with no neurologic manifestations, and she attends regular monthly follow-up visits at our hematology clinic.